Well, good morning, everyone. We're really happy to have you join us here on Happy St. Patrick's Day to those of you who are celebrating St. Patrick's Day today. I am very happy to be able to moderate this session, Nurses' Practices with Persons Experiencing Opioid Use Disorder, by Dr. Timothy Savich, who is with us today. Before we get going, I'm just going to run through a few slides here that we do because IntNSA has a contract with PCSS, which is Providers Clinical Support System, which provides all this amazing education associated with opioid use disorder. So this webinar is sponsored by the International Nurses Society on Addictions in conjunction with PCSS. Funding for this initiative was made possible in part by a grant from SAMHSA. The views expressed in written conference materials or publications and by speakers and moderators do not necessarily reflect the official policies of the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. These are the partners of PCSS, of which you can see quite amazing. There are so many professional organizations around our country that focus on opioid use disorders and the education associated with it. So you can register also to participate in PCSS discussion forums at the link shown here. It's just truly amazing. They have roundtable discussions and experts in the area. And of course, all of these are funded by SAMHSA, so they're all free. And so the PCSS mentoring program is something that if you would like to have a mentor for yourself and your facility, wherever you are, all you have to do is send them an email and they'll get back in touch with you. Okay. And And here's another piece of information about Ask a Colleague. You can send a question to this email here below, and they'd be happy to answer you. So with that, I think that we are moving along here. Robert, I don't know. Okay, there was a slide I thought about our upcoming conference, just to let you know. IntNSA is going to have its next conference there you go, at the end of February next year in Charleston, South Carolina. Planning committee is already up and running with that, and I think it's going to be a great conference, so I hope a lot of you will be able to join us. Okay, with that, I would really like to introduce to you our guest speaker today, Dr. Timothy Savich, who is an assistant professor at the University of Arizona in Tucson, Arizona. And with that, Tim, I'll just turn it over to you, so go right ahead.
Good morning, everyone. Thanks, Dana, for the introduction and for the invitation to participate in the webinar today and to lead it. So while I pull my slides up here, can everyone see that okay?
No, I'm not seeing it either. Robert, up on the main screen here.
Let's try again. Hang on one sec.
Okay. I think it's coming now. Yeah.
How's that?
There you go.
Okay, so thank you again and welcome everyone. It's just after 9 a.m. here in Tucson, Arizona. So I'm guessing it's a little bit later or maybe even a little earlier, depending on where you're zooming in from. So again, my name is Tim Savich. I'm an assistant professor here at the University of Arizona College of Nursing. And my research broadly focuses on issues around treatment access for people who have what we now call co-occurring disorders. Maybe folks still use the term dual diagnosis. So people who have at least one mental health and one substance use disorder going on at the same time. That is not necessarily what this talk is about. So the topic for today's talk is nurses' practices with persons experiencing opioid use disorder. Whether it's substance use or some other disease process or area of nursing practice, I'm always very interested, and it's much more of a philosophical or theoretical, activity, thinking about what do nurses do that sets them apart from other health professionals or social service professionals. And so sort of that was the impetus for me undertaking this narrative literature review, which I'm going to talk about today. So I have no conflicts of interest. And this paper was published in the Journal of Addictions Nursing last year. There were two co-authors. One was a graduate student at the time that I was at the University of North Carolina, and the other one was an undergraduate honors student who helped me with this and are co-authors on the paper. But I alone am responsible for the content and writing of this presentation today. So the purpose of today's presentation is to present the findings from a narrative literature review that was conducted to understand, again, nurses' practices with persons with opioid use disorder. And over on the right-hand side of the screen is just a screenshot from the Journal of Addictions Nursing. Again, this was published last year. The objectives or educational objectives for today are I hope that all the attendees are able to come away and be able to discuss the methods used for conducting this particular synthesis research, to summarize at least two findings from the review, and to analyze professional scope of practice standards for nurses' work with people with opioid use disorder. So the primary purpose in undertaking this literature review was to identify how nurses' actions, practices, and work have been presented in the literature. And I am intentionally not using the word care. I'll come back to that later on in the presentation. When I talk about my own work as a nurse and as a nurse practitioner, I tend not to, or I try to avoid the word care. It's just a personal preference, because I think that word has very specific conceptual meanings that don't necessarily or are not necessarily the same things that I'm doing in my capacity as a practitioner. A secondary purpose, though, was to summarize the characteristics of the research studies in which these appear. So, as many of you know, and for those of you who have done literature reviews in the past, regardless of the type, whether it's an integrated review or a scoping review, we really want to know what has been done so that we know what we need to do next to advance this particular area of science. This literature search, or the literature was searched between June and December of 2019. We searched for databases, CINAHL, PubMed, PsycInfo, and Scopus, and had very few inclusion criteria. So the studies had to be published in English and involve human subjects. They had to be research studies. So this is empirical knowledge, not necessarily theoretical knowledge or conceptual papers, certainly no commentaries or editorials. So anything that was included was a research study. And it had to include advanced practice registered nurses, LPNs, or RNs as study participants. And of course, the full text had to be available to us. Initially, we came up with a list of search terms, and those included things like nurses, nursing, nurse actions, nurse practice, and nurses work, as well as opioids, opioid use disorder, and heroin. And as we were doing these initial searches and kind of combing through the literature, we came across some search terms that we didn't necessarily think about at the outset. And so did another search with some of these additional keywords. And that was nurse participation, nursing care, nurse skills, and then opioid and opioid addiction. This is just a sort of a flow diagram of how we came to settle on our final sample of 21 studies. So initially we identified almost 3,000 studies, which is pretty typical for some literature reviews. This had a very narrow focus. I just read actually a literature review about nurses and integrated care for people with co-occurring disorders, and they actually screened 12,000 articles. So this is much smaller than that, but 3,000 is still pretty significant. There were a number of duplicates, and we use citation management software. I believe it was EndNote to weed out some of those duplicates. So it was just about half, little more than half were duplicate articles. So we obviously took those out of the search, which left us with 34 articles. We then eliminated some of those and then added some additional ones, which we found through a hand search of the ones that we had already accepted. So that's a very common practice. Is you find some articles that meet the inclusion criteria, then you go and look by hand through the reference list for those articles and see if you missed any, and then include those as well. So as I said, our final sample, or the final number of research studies that were included in this review, was 21. So we'll talk about data analysis now. So the first step was to read the entire article. And then what I did was to create what some people call an evidence matrix or an evidence table. And this is just a sample from 2 studies. The entire evidence table is available in the published article, the Journal of Addictions Nursing. So in the first column, we just have the authors and the location where the study was conducted, and also the year. The purpose, and I'll come back to this in just a minute. So it's what's contained here in column 2 is my sort of categorization of what the purpose was about, not necessarily the purpose that the authors indicated. And again, like I said, I'll come back to that in just a minute. In the third column we listed the design and the data collection for each of these studies. So the first one here by Chenitz from 1989, just again, this is an example. It was a qualitative study. Specifically, they used a grounded theory approach, and they collected data through participant observation, interviews, and reviewing documents. They did not use a theory at the outset of the study, but as many of you may know, the purpose of grounded theory as a research methodology is to generate a theory. And so Chenitz, the sort of deliverable or the outcome of this particular research study was a theory of managing vulnerability. Chenitz didn't specify a specific sample size because most of her data collection was done through participant observation of nurses working in one methadone clinic. And the results, I'll elaborate on this in just a few minutes as well, but these sort of abbreviations here, or one-letter codes, correspond to the practice standards for addictions nurses. And again, I'll come back to this. So, A, for example, is assessment, D is diagnosis, E is evaluation, and so on and so forth. COC is coordination of care. So continuing sort of with our data analysis. So the first thing that we did, and again, going back here, you'll see in the second column there is purpose. And the way that I arrived at things like nurses' behaviors or nurses' views was this. So I looked and read all of the purpose statements and identified keywords from them. Some people in research studies also include things like aims, so specific aims, and some people just include research questions. That's very common for qualitative studies in particular. So you may see a purpose statement, aims, and a research question, or you may see some sort of combination of those. And so what I did was read those and then pull out keywords which I categorized and then described. So I just included an example here. So one of these was perceptions, views, or perspectives. And the way I defined that was an examination or exploration or description of nurses' perceptions, views, or perspectives towards persons who use drugs. So after I did this for all 21 purpose statements or questions or aims, I came up with 4 main categories. And what these categories represent are basically what were the purpose of these 21 studies in general. And so the categories were nurses' views towards persons with opioid use disorder, which is not surprising at all. Nurses' roles, experiences, and behaviors towards persons with opioid use disorder. Some articles were related to quality of services and caring. And then a very small number of the studies were designed for the purpose of looking at competencies. And I'll elaborate on these in just a minute. Or actually, so nurses' views toward persons with opioid use disorder, those studies were, the studies that got lumped into that category were really about attitudes, beliefs, norms, perceptions, perspectives, and views, again, of nurses towards people with opioid use disorder. The second category about roles and experiences, these studies most aligned with the purpose of this review. Quality of services and caring, those were studies that were about or were designed to look at things like enhancing the quality of services and caring. It was really a mix of eclectic aims and phenomena. So for example, these were studies that may have looked at things like culturally safe care, the core of love, nurse intervention effectiveness, improving co-occurring management, and new strategies to provide care. And then this last category, competencies, were nurses' competencies. So things like knowledge, skills, and abilities towards people with substance use disorders. So here are some findings. So the 21 articles were published between 1989 and 2018. And I thought it was really interesting that the most per year, there were 3 published in 2009.
Wow.
This breakdown was kind of interesting too. So in the 1980s, I only found 1 article. That was that article by Chenitz from 1989. 2 articles in the entire 1990s. 7 in the 2000s, and then there were 11 between 2010 and 2018. So again, we had very specific eligibility criteria and inclusion criteria. I'll discuss the limitations of our search strategy at the end of the presentation. So there certainly could be more, and we could have excluded some things based on our criteria. But I wonder, and maybe we can talk at the end of the presentation, if this is surprising to anybody or sort of, consistent with what you would think would be in the literature. Again, these are just people who have opioid use disorder as well. So, these studies were not necessarily focused on other substance use disorders like tobacco or methamphetamine or cocaine or so. I think it has the potential to be a much larger body of research, but it was just interesting that so few were focused on opioid use disorder. So going back to the purpose statements again, 2 of the 21 studies were exclusively about describing nurses' actions, practices, or work. And that really was my goal in this literature search. So this too was a little bit surprising. Both were qualitative studies, and the aims included things like roles, skills, and psychosocial procedures. Others included, so all of the other, I guess, 19 studies included purposes, aims, or research questions related to the four main categories, which are those things in the blue box that I just described. So again, very few of the studies were designed with the explicit purpose of sort of explicating and describing the unique work that nurses do with people with opioid use disorder. So continuing on sort of with our findings here, this may or may not be surprising for folks. Most of the studies were qualitative studies, including action research, ethnography, grounded theory, phenomenology, and something called qualitative exploratory. And then the remainder of the studies were quantitative studies. 5 of them were non-experimental, so these were also descriptive. And there was just one that was quasi-experimental. No experimental studies at all in any of these studies. The data collection methods that were used across these studies were pretty consistent with their designs and included things like paper and web-based surveys, interviews, whether those were focus groups or individual one-on-one interviews, observations, field notes, document reviews, and video recordings. Theory. So I think as a researcher, part of my job is to be concerned about nursing theory. I know that it's not everyone's favorite subject or cup of tea. And sometimes I understand why, but, you know, I'm in the business of sort of not only generating empirical evidence and empirical research, but thinking through the theoretical aspects of what is nursing and what is it that nurses do or can do. So I'm always very interested in looking at how, if and how, other scientists and researchers are using theory in their studies. So only 6 of the 21 studies included a theory. 3 of those were qualitative studies and 3 of them were quantitative studies. This is not a surprising finding to me. It's very common for people who conduct research to not necessarily use or to write about explicitly a particular theory that they used. Theory kind of shows up, particularly in qualitative research, in lots of different ways. So sometimes it's woven throughout it, it's just not so explicit. So, but I was explicitly looking for any mention of any theory, nursing or borrowed from some other practice, profession, or discipline. Only 4 of the 21 articles had a section devoted to theory in the actual article. That may have been intentional on the author's part. That could have been related to guidelines from the journal. I've never seen a journal that offered advice to exclude a theory. So I think that's probably less of the issue, and it was just people not talking about it or not thinking about it. The use of the theory was not always explicit. So, for example, a lot of times in qualitative research, researchers will use a theory to generate some initial interview questions. They're not necessarily looking at the different concepts and propositions of the theory to test. And it was not always clear across these studies. And as I mentioned a little bit ago, there were some theories created through the grounded theory approach. So the first one was managing vulnerability and nursing attitudes towards patients with substance use disorder and pain, another grounded theory. So the findings across the 21 studies in terms of samples and settings, obviously one of the inclusion criteria was that the nurses needed to be included as participants There were some studies where the participants were nurses, but there were also other participants like other healthcare professionals, perhaps physicians or social workers. And then in some studies, patients were also included alongside of nurses as participants. Nurses were described, and again, these studies were not limited to the United States or North America, and so nurses are described differently and, depending on geographic location. So some of them were described as RNs, midwives, public health nurses, community addiction nurses, district nurses, staff nurses, nurse educators and managers, and nurse practitioners. 8 studies were conducted in Europe, 7 in North America, 2 from Asia, 3 from Australia, 1 from New Zealand, and 43% of the 21 studies took place in a hospital or medical center. So very, coming up on half, we're really focused on the acute care setting and the nursing work that happens in those acute care settings. At least here in the United States, I'm not sure how many of our colleagues joining us today are outside of the United States, but our undergraduate educational structure really focuses on preparing nurses to enter acute care settings. There's less emphasis on community and public health, certainly less emphasis on primary care. And as somebody who practiced for a long time as a family nurse practitioner in primary care, I saw how differently and the different types of work that the RNs that I work with in those settings did than in the acute care setting. It's a completely different skill set that isn't necessarily the emphasis of undergraduate education here in the States, which I think is interesting and just something to consider, because if we think about where the care of, or most of the care happens for folks with substance use disorders, it's likely happening in the community, through public health and community agencies once people are stable and, out of danger. Now we're going to focus on the results. And I know it's confusing here because I have findings and results. So the findings pertain to the findings from the narrative literature review. Results means specifically looking at the results of each of the 21 studies. So the way that I analyzed the results from each of the individual 21 studies was to look for single words or phrases, either the authors or the research participants, about nurses' practices. And then I labeled them using the ANA and IntNSA standards of practice for addictions nursing. Because this was conducted several years ago, I was using the 2013 edition of the standards and scopes of practice. But as many of you know, a new 3rd edition was recently published, and that's available. All of the standards of practice were referenced except for prescriptive authority and treatment. And only 2 articles included APRN applicants. So one of the studies included Canadian nurse practitioners who could not prescribe controlled substances at the time of the study. And there was a second study that just included certified nurse midwives. And the study was not necessarily about their prescribing practices. So this is just a reminder for all of you. This is pretty familiar to many people, particularly those who live and work in the US. So the standards of practice for addictions nursing are assessment, diagnosis, outcomes identification, planning, implementation, which has 4 subcategories or sub-practices, and evaluation. And again, these were the things that I used to label individual words or phrases in the results of the 21 studies. To try and better understand, where's the research been done? Have we done a lot of research about assessment? And do we know enough about how nurses assess, how that actually plays out in clinical practice? Can we move on to some other things or, sort of where are our deficits in what we know about nurses' practices. So here are the results of the results, basically. So they're listed in order of frequency. So implementation was the practice standard that I found the most. I found it in 18 of the 21 studies, so that's 86% of our sample. And then you can see the breakdown of those subcategories. So coordination of care, health teaching and health promotion was contained in 8 studies, and then consultation was just in 1. And some examples of words or phrases that I found in the results were preparing or administering medications, conducting group therapy, and managing an overdose. Assessment was the next most common practice standard that I identified across the studies. I found examples of it in 14 of the studies, or 67% of the sample. And these were things like monitoring for signs of neonatal abstinence syndrome, measuring vital signs, and recognizing signs of intoxication. Evaluation was the next practice standard that appeared most frequently in 8 of the 21 studies, or 38% of the sample. And these were things like evaluation of care, surveillance, words like follow-up or use of a sedation checklist. Diagnosis came next, both diagnosis and planning. I found instances of those in just 4 of the 21 studies, or 19% of the sample. And for diagnosis, they were specifically talked about diagnosing intoxication, overdoses, or problematic drug use. And for planning, these were words like, or phrases like discharge planning or planning nurse-led interventions. And then interestingly, outcomes identification is only appeared in one study, or 5% of the sample. And the authors were talking about identifying behavior change, but which behaviors and how that change was measured were not specified. And just one point, in general about the results of these studies is that the level of specific actions for practices, or for actions, practices, and work really varied. For example, it was very common to see phrases like nursing duties and provide care. And those are very generic. So it's really hard to tease those apart. For the author, those probably mean very specific things, but they may mean different things for the reader. And so those words tend to be frustrating as a researcher who's trying to understand what is it that nurses do that sets them apart from all the other people who are involved in the treatment of people with opioid use disorder. And this goes back to, I think, long-standing issues in nursing. Are nurses just simply doing the tasks that are kind of ordered by other people? Are they actually doing nursing work that is very different from other healthcare providers? Care, as I mentioned at the start of this presentation, was frequently included as a practice, but wasn't always defined and elaborated upon, and was typically preceded by various adjectives like equitable care or nursing care or comprehensive care. And again, each of those concepts may or may not have sort of a conceptual definition, but how that's operationalized by different stakeholders is very different as well. So I think the word care can be problematic because it means different things for different people. And I know Dana is at the University of Colorado, where the great Gene Watson was, who did so much of this seminal work on care. So I'm actually beginning a study right now with a colleague here looking at the concepts of care and compassion. And so I think that they're important. I think that we just have to use them very carefully because, again, they mean things. not only differently to nurses, but also the people who are the recipients of nursing services or nursing care. Moving on to the limitations. So the limitations of my review in general, not necessarily the limitations for each of the 21 studies. So again, as I read and reread these 21 articles, some key words that I hadn't considered initially sprung up for me. So, and those things included like behaviors, competencies, management, norms, procedures, roles, or strategies. And so I think if I were to repeat this literature review in the future, I would also include these. My guess is we may find a couple more studies in the same range that we may have missed initially because these weren't included in the search strategy. Another limitation was that this was only published research. So we did not look at unpublished research, including, excuse me, perhaps master's theses, dissertations. Now we have DMP projects, some of which may actually fall into the category of human subjects research, or research more generally. Particularly, I think in the early days of DMP programs, I've taught in a few of them now, and I think faculty have different ideas about the differences between research and non-research. And so I think that's probably a treasure trove of potential research that we just didn't consider. And again, only articles that were in English and in full text format were included. So that just leads me to some discussion points related to, kind of findings from this narrative literature review. And then I think we'll have some time to do some Q&A, which I hope folks, we can engage in these questions or dialogue points don't necessarily have to be related to the review, but more about nursing of people with substance abuses in general. So a good thing is that there was an increase every decade since the 1980s in the number of published studies. 52% were published between 2000 and 2018. So, more than half in just, almost 2 decades. There may be lots of reasons for that. Many of you on the webinar today who are in the United States know that for the past several years, there's been a lot of media attention and coverage about the opioid epidemic or opioid crisis. And so because that's sort of come to, and certainly the increase in the number of fatal overdoses, I think it's maybe 107,000 from 2021 data. And somebody can correct me if that is wrong. But there's just been a lot more emphasis on opioid use and opioid use disorder. And so that increase in the 2000s, between 2000 and 2018, may just parallel our increased awareness of the issue. The practice standards served as a useful framework, which I really appreciated. Their ubiquity. So the ANA IntNSA practice standards are also used by other specialty nurses and generalist nurses as well. So assessment, diagnosis, planning, evaluation, implementation, those are all very common beginning as undergraduates, in our undergraduate education. But I wonder sometimes, does their ubiquity impact knowledge development about their use during practice? So do we as nurses, not only practicing nurses, but people who are in nursing education and research, do we take for granted that we know when somebody is talking about assessment, what it is that they're doing? I think sometimes these practice standards can be used to kind of lump things together, and we never really get to the granular level to figure out what specifically nurses are doing and how, again, that's different or differentiates themselves or maybe making much more of an impact than some of the other things we think are helping. So it's just something to consider. All of the practice standards, as you know, if you've ever looked at them, include much more specific competencies, which are also very helpful. And I think one of the things that we can think about going forward, if folks want to continue down this road of looking at nurses' practices with people with substance use disorders, not necessarily opioids, but how can we add to those competencies? What are the competencies that people are new or have been doing for a long time that we really just haven't thought about or recognized? So I think that this work has sort of the advantage of advancing those competencies. And for those of you, again, in the US, our sort of educational oversight bodies are really moving, and also for DNP education as well, really moving towards competency-based learning. So competencies are going to become even more important. And I think really thinking about what those competencies are when it comes to addictions nursing is really important. Again, the specificity of practice is varied. And I really do think it's important disciplinarily and professionally that we be able to differentiate the work that we're doing from the very important work that our other health and social service providers are doing. Collecting data about and from patients and implementing treatment plans were the most common practices that I identified. I don't think that this is surprising. I think whether you're working in addictions or not, this is a lot of what nurses do, across practice settings. They're talking to patients, they're collecting information from them and data about them. And then they're also implementing treatment plans that haven't necessarily been, so they're implementing treatment plans that have been dictated by some other type of provider. Here, I'm not talking about implementing a nursing treatment plan. So, somebody orders a liter of normal saline and they're hanging and administering the saline. Nothing that I found was specific about this is the nursing intervention and treatment that I have now planned and I'm going to implement. So it's another area I think that's very interesting. There was a near absence of the practice standard of identifying outcomes. I thought this was really interesting. And again, the practice standards, the ANA and IntNSA practice standards include lots of great competencies. And the competencies associated with identifying outcomes are really formulating, documenting, and modifying them. I thought this was so interesting because, again, it speaks to, at least from the work in the literature that we know, is that nurses are doers. So they're doing the things that have been ordered for patients or that have been recommended for patients. But they're not necessarily thinking about and documenting other outcomes related to their care as nurses. And maybe that's because those skills about how do you identify an appropriate outcome, and then how do you evaluate whether that outcome was met or not, perhaps those are not emphasized so much in nursing education, particularly at the undergraduate level. I think people who are in advanced practice roles do this, but it's really under the umbrella sort of the medical model. So, when you see somebody, you make a diagnosis, you prescribe a treatment, you usually follow up and see how that treatment is working. So maybe this is somebody who has, essential hypertension and you just diagnose them, you're going to see them back every couple months. So you're seeing how the outcome of a blood pressure management changes based on your intervention. And I'm not sure that nurses are being taught, particularly at the undergraduate level, to think about their practice in those terms. We have the NANDA International Nursing Diagnoses. It's been more than 20 years since I finished my undergraduate program. I don't know if these are still included in undergraduate programs or emphasized in undergraduate programs, but I certainly think that they're helpful in nurses understanding how they can formulate and document outcomes. And I just had an example here. So an example of a NANDA International Nursing diagnosis is risk for impaired liver function. And so this is applicable certainly for people who are injecting heroin, because they can easily be infected with hepatitis C or some other form of hepatitis, which, if untreated or left undiagnosed, can cause problems down the road for folks. And again, outcomes that nurses could easily identify and be involved with and evaluate are things like using clean supplies, and then making sure that the patients that they're coming into contact with who are injecting heroin have had a recent hepatitis screening, along with other, appropriate screenings. APRNs were underrepresented. Again, they only appeared in 2 studies. So I think that is an area that is in need of further research. What is it that advanced practice nurses, whether, midwives or nurse practitioners, are doing specifically to take care of people with opioid use disorder? And then African and South American nurses were just not represented in the literature. And so opioid use disorder, how it's identified, how it's treated, how it's thought about at a societal level, likely varies by geographical region. And so I think it's really important for those of us who are interested in looking at nurses' work in various parts of the globe, is something that we need to beef up a little bit. And then again, nursing theories, or theories at all, were infrequently used. 2 new theories were developed. And I think that I am someone who believes that middle range and situation specific theory should guide practice. Practice helps very much in the development of theories, but then we need to use those theories to guide our practice. And I don't think that that is necessarily always the case. So I think there's some room here for folks who are interested in this area of research for some theoretical development in these areas. And a great example, it's an older article, but it's really one of the best articles that I've read by Chenitz from 1989 about. The beauty of it is that she observed nurses in a methadone clinic. It could have been very easy to just list all of the things that the nurses were doing, giving out the methadone, dosing the methadone, taking off the orders for the methadone. But the work that she observed that the nurses were doing was so much more. It really came down to managing all these people's vulnerabilities, which is so much more specific and nursing centric than just doling out methadone all day. So I encourage anyone who's interested in theoretical development, particularly around practice, this would be a great area to develop. So 3 conclusions from the actual published paper. Knowing what nurses have been doing is essential for envisioning how these practices may be expanded and refined in the future. Second concluding point is that practices could be further examined, for example, developing situation-specific theories and tested. For example, what's the association between time spent with patients during telephone triage and retention in opioid use disorder treatment? And then articulating specific competencies associated with each practice standard is essential for identifying nurses' unique knowledge base, contributions to the treatment of persons with opioid use disorder, and uncovering ways in which this large sector of the healthcare workforce can contribute to tackling the U.S. opioid epidemic. Thank you. Here's my telephone number and email address. Feel free to contact me at any time. I always love dialoguing with folks. And now I think we have some time for questions and answers or just general conversation. So thanks again for the invitation, and I look forward to the dialogue.
Tim, thank you so much. That was absolutely wonderful and excellent. And while you've been talking, we've had some very interesting remarks going on in the chat box, particularly related to nurses' roles and scope of practice in countries outside of the United States, because of course, IntNSA is really kind of growing and internationally. And the other thing I think that you did was you really increased you motivated a lot of people to look at theory a little bit more. I've always been very interested in being at the University of Colorado many years ago. I went to a week-long retreat with Gene Watson in Boulder, Colorado, and that was fabulous. But just things like decreasing stigma, increasing competencies. So if anybody has any questions, there's a few in the chat. I've sort of related to what they would have just been talking about. But if you would raise your hand, because at one time I saw we had 156 people here. So if anyone has any questions, please let us know. If you'd like to ask Tim something.
I'm very informal. I didn't say this. I have never worked specifically in the area of mental health or addiction or substance use disorders per se. I was a generalist RN, so I've always worked as an RN in large medical centers with general medical patients, some of which had mental health issues going on, some of which had substance use disorders going on. And as a nurse practitioner, did family practice. So, I'd see a 2-day-old in, one visit and a 98-year-old. And so again, these people not only had physical, but mental health, pain issues, substance use issues. So I am not an expert in the nursing care of people with addictions. I look at substance use and mental health issues because I think it's an interesting lens to look at bigger issues around treatment access. So I should have said at the beginning. So I welcome anyone who's been practicing as a nurse or an advanced practice nurse for a long time in this area to tell me like, this is bogus or you really missed the boat, or to agree with me and say we don't do a great job of really articulating and sharing what it is that we do that really differentiates us.
We have a question, Becca Carty, and then Jane West. You want to go first, Becca?
Yeah, thank you. So my name is Becca. I am actually an RN, and I am the primary clinician in a low barrier buprenorphine clinic. We work out of our local health department. And I just wanted to say, like, in my experience, from what I've seen, I've been doing this job for about 4 years. And prior to that, I had 8 years in the emergency department. If I went back to the emergency department, the way that I would treat people would be very different. We, in nursing, like one of the huge lacks in our education is anything other than essentially following an order. And you learn a lot of that on the job, but we, in general, at least in the United States, are very bad with how we're managing to treat people with substance use disorder in general, and also how we are encouraging people to like find other ways of caring for their pain or caring for their like emotional distress, so we can maybe help them not go down that road in the first place. Basically, it's really awesome that you are getting into this with research. It makes me pretty excited, and I want to try and look for some opportunities where I could get involved in that myself. We are involved in research. Like my clinic is a grant funded clinic. So there is some research coming out of this, but it's not specifically related to the way that a nurse participates in treatment. So
Yes.
Pretty cool.
Thank you for your comments. I really appreciate it. And, it's true. I think particularly, and again, I have been a clinician and a practitioner more than I've been a researcher. And so I very much identify as a clinician researcher. Many of my research questions are clinically based. And so I think that practicing nurses are instrumental in helping researchers to generate really important and timely research questions. And so, yes, please feel free if you ever want to talk through that or explore other avenues as well. So thank you for that.
That's great, Tim. Thanks. And then Jan, go ahead. Then I see Kristen. Okay.
Okay, so one of the things that really has been the foundation of my nursing practice was that my initial nursing program was based on nursing theory, PAPLAU.
Mhm.
And I've worked through many different areas. And I even had a stint teaching. When you said the comment about working in acute care and stuff like that, I was thinking that one of my students said to me that they can't wait to, not work in psychiatry because then they won't have to think again. The research shows that 85% of every single person who is hospitalized have a mental health diagnosis. So my concern is really how amazingly shocked I am that anyone can, even consider that not to be a very foundational aspect of our profession. So that's the reason I raised my hands. I felt like I just absolutely had to.
Thank you, Jan.
So
I'm glad you did. Thank you for sharing that. And I agree with you.
Yeah, I do too. I see Kristen Wilson Weberg. Go ahead.
Yep. Hi, I'm Kristen. I'm a public health nurse. King County. I actually work in our needle exchange, focusing on hepatitis C treatment and testing, and I help out with our Suboxone program as well. And I'm just kind of excited to see that there's some reaching out and hopeful that our patients can be treated with respect. And I'm very much into the harm reduction work. I got to attend the harm reduction conference in Puerto Rico this past year, and it was amazing. But I'm just so thankful and hopeful, I guess. And I just want to thank you, Dr. Soetz, for providing this amazing webinar. Thank you.
Yeah, and thank you for all the very important. The work that you're doing is much more important than the work that I'm doing. So, it's all important. But thank you for everything that you're doing to
thank you
to take care of people.
Yep,
Yeah,
thank you.
I think you're right. I think it's all important. Suzanne Hannon, go ahead.
Hi, can you hear me?
Yes.
I'm on my phone. Yeah, okay. The screen says I'm off. This says I'm on. Okay, so I'm really intrigued by something in the middle of your talk. I'll tell you first. I'm a pain nurse, practitioner. I'm responsible for inpatient pain management in a small hospital in New York City, and so I see we don't have an addiction specialist, so I see a lot of people experiencing opioid use disorder in the context of medical illness and mental illness, and the whole bucket. Many people, of course, with pain have some need for mental health support, but that's why I listen to these webinars. But in the middle, you said something about the near absence of identifying outcomes, and then you talked about NANDA. So when I was in nursing school, and I went as a middle-aged adult in 1990, there was a lot of emphasis on nursing diagnoses. And what I saw in them was this attempt to be more medical, to match, like we can't have a separate nursing science. We have to be, we have to be just like the doctors, and so we formulated nursing diagnoses. And we continue to use them. You know, it's like I open up Epic and I'm looking at the patient's notes, and I will see, you know, knowledge deficit or high risk for injury, and there are all these tasks. And yet, many of the comments or the focus is all of the nurses is accounting for, in their notes, you know, more of the medical aspects, you know, or else they're, you know, not identifying some of the more important aspects, like what the medication they're giving really is for, as opposed to what it might have been for in the drug pharmacy manual. But so I think that the nursing diagnoses actually contribute to the inability to identify outcomes, because when we identify outcomes, they might be more in terms of how the patient fared in a medical environment. I do inpatient, so that's more of what I see. And of course, you know, everything is geared towards discharge, you know, and also the nursing diagnoses are so cumbersome. So I think that's part of the difficulty in reading research and identifying outcomes in terms of what nurses do at the bedside, or, you know, not, or in the clinic, you know, and that stuff about the impact of follow-up calls, check a patient, how a patient is doing or feeling, or, you know, that kind of thing. So I think that's just a difficulty inherent in our system, or a way of preparing students to think.
Yeah, Suzanne, I agree with you wholeheartedly. And I think that truly is probably the impetus for this work, was to say, we have to take it upon ourselves to figure out what it is that we're actually doing that's unique and different from what others are doing. I think for me, that's the only way we're going to sort of propel our profession and really highlight our expertise, aside from, you know, what others are doing. So I appreciate your comment. Thank you.
I thank you too. This is a great example, all of you who've had questions and are putting your comments and questions in the chat, of how wonderful it is to be able to network with each other, not just nurses, but with other health professionals as well. And so I thank you, Dr. Tim Savage. It was incredibly wonderful. I've gained a lot from it. We really appreciate your being here. And I want everyone to know that all of these webinars that IntNSA does are available and free, recorded on our website under our virtual learning classroom. They're also available under the PCSS website, which offers all of the recordings from other organizations about opioid use disorder on PCSS. So I would ask you, if you're not, to really seriously consider joining the International Nurses Society on Addictions. And we, again, are having the conference. Our conference chair, I see, is here, Phyllis Raynor at the University of South Carolina. She's going to chair the conference planning committee and the conference for Charleston Conference at the end of February next year. And also thank you so much for the comments. And we've also had Dr. Carmel Clancy, the president of IntNSA, with us today, and Dr. Catherine Ferneely, who is the immediate past president of IntNSA. So great organization, lots of networking. We encourage conversation, innovative ideas. And thank you so much again for being here today. With that, we will say, have a great rest of your day.